Okay, now we looked at a respiratory function test in the first lecture yesterday, and this is, in a way, it's almost the same test, but it's plotted differently, and so this is a flow volume curve. Okay, and so what we have is volume on the x-axis, and for inscrutable reasons, the volume increases as we go to the left. So on the right side, we have residual volume. On the left side, we have total lung capacity. And then on the y-axis, we have airflow. So flow out goes up and flow in goes down. Okay, and so the ideal flow volume curve goes up very quickly to a large maximal expiratory flow rate, and then it decreases as we go down towards residual volume. Okay, and then during the inspiratory loop, it has kind of a slightly different shape. Okay, so the way you do this flow volume curve is pretty much the same as our spirometry test. So here's a person just breathing normally, and this is a real curve. Okay, so you're breathing in and out. Okay, just normal tidal breathing. Now you tell the subject to breathe in to totally fill their lungs. Okay, up to total lung capacity, and then you tell them to blow all the air out of their lungs as fast as they can. Okay, so it's like, okay, and then you have them breathe in and totally fill their lungs as fast as they can. Okay, go. Okay, so that's the whole loop, and it has this kind of characteristic shape, and the expiratory flow looks different than the inspiratory flow. Okay, and a major reason for this is that air is flowing through the airways, the bronchi and the bronchioles, and these airways are located within the lungs, within the thoracic cavity. If you expand the thoracic cavity up to total lung capacity, you're going to stretch these airways to a larger diameter. So that's going to decrease their resistance from Poiseuille's equation. So from total lung capacity, we're sitting at as large a volume as we can get, and we exert a maximal expiratory effort, contract our expiratory muscles, and we get a large expiratory flow rate. Okay, and even though we're maintaining maximal effort, the flow decreases more and more as we go to smaller volumes. And one of the reasons for this, of course, the pressure gradient is dissipating, but also the airways, as we go to smaller volumes, the airway diameter is decreasing, and their resistance is increasing. Okay, so now we're down at residual volume, and we start our maximal inspiration. Okay, so we exert a maximal effort, and we get a pretty decent inflow, but then it stays relatively constant for a wide distance. So what's happening is that we exerted the maximal effort, and so we get a lot of airflow, but the tubes, the airways are narrow, and their resistance is high. So even though the pressure gradient is now dissipating, the diameter is getting bigger as we're expanding the lungs, as we're inflating the lungs. And so the airway resistance is decreasing, and so we maintain this fairly high flow rate over a larger period of time. And then we finally get back up to total lung capacity. Okay. Right, so here we have our tidal breathing. We inflate our lungs maximally, okay, and the normal flow volume curve is with maximal effort, and that's shown here. Okay, now what if the subject exerts a moderate effort and not a maximal effort? Okay, you start at total lung capacity, instead of they're going. Okay, so they now have a much lower maximal flow rate, but they maintain this flow rate for a period of time, and then eventually it joins the same curve on the way down. Or with a minimal effort. So they sustain this flow for a long time. At the end, it joins the same curve on the way down. And if you do this over a whole range of different efforts, the more effort, the greater the expiratory flow rate, but on the way down, all these curves join to the same curve. Okay, and so this part of the curve is called the effort-independent region. And it's effort-independent because exerting a greater effort will not result in greater airflow. Okay, and the reason for this is dynamic compliance of the airways, dynamic compression of the airways. Okay, and we're going to talk about that in just a couple seconds. Okay, so we have our normal flow volume curve here. Okay, so have a quick look at what happens to the flow volume curves in the two classes of pulmonary disease. In restrictive diseases, pulmonary fibrosis, the flow rates may be relatively normal, the airways are okay, but the total lung capacity is lower because the fibrosis restricts the inflation of the lungs. Okay, the elastic recoil is too high, the compliance is too low. With a maximal effort, the lungs can only be inflated to a smaller than normal amount, and so the fibrotic patient is operating at lower absolute lung volumes. Okay. With emphysema, we have the opposite situation. Total lung capacity is increased, okay, and part of the reason for this is that the recoil of the lungs is very weak, okay, and so the chest wall wins out in the competition between the chest wall pulling out and the lungs pulling in, so the chest wall dominates, okay, and then there are other factors which will kind of lead to this getting worse and worse, but the key factor in emphysema is a slowing of forced expiration. So even though they're at a high volume, the maximal forced expiratory flow rate is greatly reduced. And it's greatly reduced because of dynamic compression of the airways. Okay, so here's our normal flow volume curve, and this is the flow volume curve in emphysema. Okay, and just as a reminder, emphysema is a disease in which the air spaces distal to the terminal bronchioles are enlarged and their walls are destroyed. So we have loss of lung parenchyma, elastic recoil of the lungs is weak. Okay, and a clinical sign of emphysema is a slowing of forced expiration. So here's our normal peak expiratory flow rate, and with emphysema it's greatly reduced. And the normal comes down like this. With emphysema, we have this little spike of expiratory flow, but then the flow rate is very low over the rest of the range. And you can see that here we have our tidal breathing, and with a forced expiration, we're already down to what we were doing with just normal breathing. Okay, so this is due to dynamic compression of the airways, so let's try to understand this. Okay, dynamic compression is the reason that this too high compliance in emphysema is a problem. Okay,